We are moving on to Irene next. She practices in Canada, has been teaching all over the world, has been very active in research and publication, and I'm very much looking forward to her presentation and learning from it.
Thank you, Mike, for the invitation. I'm very excited to talk to you guys about this topic here. And the objective of the next 15 minutes, I'm going to go over the following. I want to talk about the differences between point-of-care ultrasound use in internal medicine as compared to its use in emergency medicine or critical care. Specifically, and as Mike said earlier, those are the founding fathers of POCUS. The second thing I wanted to kind of highlight on are the ways that which in internal medicine we can benefit from learning other specialties. So by way of disclosure, even though I am a practicing internist, I was trained by emergency medicine ultrasound. So the training that I got was entirely through the emergency medicine world. And I did that at the Massachusetts General Hospital. And I remember during my emergency ultrasound fellowship training that year that I was learning stuff that I thought I would apply essentially only in the emergency department, that I wouldn't be using that once I'm back home as an internist again. Specifically things like looking at the intrauterine pregnancies or looking at shoulder dislocations. I learned that, but I wasn't sure that I would use that. Having said that, I'd have to say I'm really glad I learned that, because we do look after pregnant patients. Here's a clip of a patient, and I guess, yeah, I think it's probably showing relatively slowly on your screen there. But essentially, pregnant patients do have fetuses, that it's not the worst thing to actually assess the fetal heart rate prior to obstetrics getting there when I'm evaluating them for shortness of breath or other medical complaints in the pregnant patient. And if I didn't learn shoulder dislocation, I may not have had the opportunity or understanding of the anatomy to really evaluate the shoulder effusion in the glenohumeral joint. And I apologize, I don't think that you may not be able to see my cursor, but there's a small effusion here in the glenohumeral joint in the right shoulder. Other creative uses of ultrasound, I mean, I learned about the water bath, and I'm pretty sure that emergency medicine or critical care colleagues probably don't care about clubbing as much as we do as internists. Here's a paper that our trainees published on the use of point-of-care ultrasound in evaluation of clubbing, so that you can actually measure the angles a lot better, so that if you compare that to the JAMA series, you can actually get more accurate angles. So those are fun and creative ways of doing ultrasound, using the same skills, but a slightly different way in internal medicine. Now I'm going to turn my attention now to talking about really key differences between how we might use point-of-care ultrasound as internists as compared to emergency medicine and critical care colleagues. So the three areas I'm going to touch on are first the patient here on the bottom left, and then on the right side would be indications of formal imaging, or those done in or consultative imaging studies done in the radiology department, be it ultrasound, CT, X-rays, MRIs, etc. In the very top there, you'll see, you know, I'm trying to talk about the literature that's covering the point-of-care ultrasound use. So how we use point-of-care ultrasound at the bedside, whether or not you use it to replace formal consultative imaging studies or you use it as an adjunct to physical examination, probably depends on a number of factors, and there's a lot of debate in the current environment about how internists should be using this. But I'm going to go over this in a little bit more details. I'm going to start with imaging studies done in radiology department. In the emergency medicine world, this is, you know, the type of patients that they deal with, and they are often too sick to go to the radiology suite to get formal imaging studies done. So point of care bedside ultrasound would probably have to replace some of those formal imaging studies. In our world, at least in my world, in internal medicine here, our patients are sick, but they're not that often too unstable to get formal consultative imaging studies. So whether I use my point-of-care ultrasound to replace formal imaging studies depend on a number of factors, including availability of these imaging studies, the timing of when I can get them, and costs. And costs, I don't only mean monetary costs, I also do mean costs in terms of, would it become unsafe for the patient to go to the radiology suites to get these tests done, etc. And I can't speak for all of internists throughout the world because it really does depend on where you practice. In my center, for instance, the argument for availability timing isn't really there because I actually do get readily available DVT scans the day I want it. I get readily available CT scans the day I want it. So I don't necessarily think that point-of-care ultrasound is helpful to replace it in my setting. Cost-wise, we're a single-payer system, so I mean, there's some argument to cost savings. Having said that, the way I use it is not necessarily to completely replace radiology. In fact, rarely do I do that, but I do that more in a bedside situation. The next comment I want to comment on is really the patient mix differences in emergency medicine and critical care versus the patients that we do see. And I think Jose kind of illustrated some of those differences as well. As you may or may not know, there's good literature to back up the use of ultrasound in assessing patients in acute respiratory failure. Is it CHF? Is it COPD? Is it pneumonia, PE, or acute coronary syndrome? What could it be that's causing this patient's profound acute respiratory failure? And if you may or may not be familiar with Lichtenstein's Blue Protocol. Here's only one of the examples of how to assess a patient in this situation. And he outlined fairly cleanly a number of things that you can look for that would suggest pulmonary edema versus pneumonia versus pneumothorax versus PE, etc. So there are a number of things that you can do that can explain a patient's acute respiratory failure. The difficulty with applying that in our internal medicine setting is that our patients aren't coming necessarily in with acute respiratory failure, but rather they're a little bit short of breath, a little bit more so than usual. And it's actually not super uncommon for internists, and I think most of you who are practicing internists probably see this not on an infrequent basis. For instance, a common scenario would be a patient presenting in with pneumonia, which then subsequently precipitated their congestive heart failure, which made their pre-existing COPD worse as well. And all that led to an acute coronary or demand ischemia. And if they sit around on the ward long enough, it's highly possible that they develop a PE subsequently as well. So our patients have multiple findings, all of which can explain their presenting complaint. And another common scenario that many of you may have come across would be a PE as the initial event that then precipitated their COPD exacerbation symptoms, which led to a demand ischemia, which then worsened their pre-existing heart failure. So I mean, the long and short of it is that we probably end up seeing multiple findings, and that's kind of what we do at the bedside anyway, with or without ultrasound, is to try to sort all these things out. The next big differences in terms of applying ultrasound in our patient population is just the florid number of chronic diseases that they come in with. And many of my patients have a problem list of 10 to 20, and it's not that uncommon. So in terms of chronic diseases that will impact the point-of-care ultrasound findings in the setting of finding free fluid in the abdomen, while our cirrhosis patients with ascites or peritoneal dialysis patients will chronically have that. Finding pericardial effusion really need to take into account of whether or not patients, with autoimmune diseases, thyroid diseases, end-stage renal diseases, and malignancy. It's not that uncommon for them to chronically have pericardial effusions. Same with B-lines in patients in interstitial lung diseases or pulmonary fibrosis. They may always have B-lines, and patients with pulmonary hypertension may always have a dilated RV, right ventricle. So in assessing echo findings, we really need to take into account the chronic diseases and try to sort out what's the new finding. So here's a slide, and I don't know how slowly it's showing on your slide there, but what you can see is a little bit of, this is outside the screen there, there's some suggestions of B lines, but definitely some clear subpleural irregularity here. And this is a patient with idiopathic pulmonary fibrosis, or IPF. In this patient, this is their baseline lung ultrasound. So using that to make clinical decision, you really need to know what they might at baseline look like. In terms of right-sided findings, this is a patient with pulmonary hypertension with an RVSP of over 90, and this is that patient's baseline echocardiogram, where there is that D sign, the flattening of the septum between the left and the right ventricle, and a fairly dilated right ventricle and the apical four-chamber on the right here. So again, you know, when deciding what may have been worsening in the patient, you sort of do need to know the baseline of your patient. So the third area I'm going to touch on is really in terms of literature. Here's a study that looked at emergency physician performed DVT scans, and in a systematic review of 16 studies, that's comprising close to 2,400 patients, the diagnostic parameters for doing a DVT scan is fantastic, with very high sensitivity, specificity, high likelihood ratio, and a very, very low negative likelihood ratio. But the major problem in applying this study to our patient that, say, I might be called to assess post-op knee with a red swollen leg, using point-of-care ultrasound to rule out in a very high pretest probability is probably not wise, despite what the literature suggests, because the literature is looking at emergency medicine patients who are by far and large walking into the emergency department. So is all lost? And obviously no, because I use ultrasound every single day. In terms of chronic diseases wise, if you know what the patient's baseline looks like, using it to monitor subsequently is extremely useful. In a patient with chronic interstitial lung disease, if you know what their B lines normally look like, and they come in with bigger, wider, more confluent B lines, then there's argument to be made that maybe there's a higher degree amount of fluid, especially if those B lines go away with diuresis. In terms of using bedside ultrasound for those who are uncomfortable, and I think Anna commented on some of the resistance in internists in using ultrasound. We're doing a lot of sophisticated maneuvers on our patients already when we examine our patients. So let's say I'm trying to assess for pleural effusion in my patient using, as many of the physical examination techniques as I can. The evidence would suggest, and based on Stephen McGee's book, that using physical examination finding has a pretty good positive likelihood ratio for the assessment of pleural effusion. So if you have asymmetric chest expansion, reduced tactile fremitus, it will push your pretest probability higher after your physical examinations of the patient. So what does that mean? So if all comers to my medical ward has about 10% chance of having pleural effusion, using physical examination alone will probably lift it up close to somewhere between 50 and 60% post-test probability, which suggests that the patient has a higher chance of having pleural effusion. But the certainty certainly isn't really that great still, which is why most of us before the ultrasound era would resort to a chest X-ray. If, however, on the other hand, you see this on ultrasound, which here, just to walk you through, is a lung at the top here surrounded by pleural effusion, and you can see the spine through that and the diaphragm to the right. If you see actual pleural effusion and you're trained to use point-of-care ultrasound, you know what you're interpreting. Well, the literature suggests that the likelihood ratio is actually probably in the 50s range. maybe as low as 11. That's still higher than physical examination. The confidence interval here is clearly quite wide, as high as 254. Well, what can you do with that likelihood ratio? It doesn't tell you perfectly that you 100% have pleural effusion, although it's looking that way. But the least you can do is walk away and say, actually, now my post-test probability is a little bit higher. I'm a little bit more confident that the patient has pleural effusion. And I think this will help out our internal medicine colleague who is a little bit reluctant on using ultrasound as they start their try to incorporate it to their practice. And really, the worst case scenario is that you don't use the findings to make any changes to your pre or post-test probability, and you stick to your physical examination skills, and you say that the pre-test probability is still somewhere between 50 and 60%. At least no harm is done. So that's kind of summarizes all the areas that I wanted to touch on. And really, if many folks are uncomfortable using bedside to replace formal imaging, and I would encourage you, and I would assure you that you shouldn't have to. But using it directly at the bedside should allow you to more confidently assess your patients. So in summary, I kind of went over the factors to keep in mind when you're applying POCUS in internal medicine, specifically the differences in the patients. Then they're sick, but they're not that sick. They have tons of comorbidities that you need to account for. So that kind of covers how you would use POCUS in the internal medicine setting. And also it's probably specific to your site of practice as well, and how you use it might differ from how I'm going to use it at my center. Think about the evidence that you're going to use when you apply it to your patient care. And lastly, I think we can probably all agree that POCUS can help you change your pretest probability after you examine the patient. And with that, I'm going to turn back over to Mike.
Thank you very much, Irene. That was a great presentation. And I always love seeing and hearing how a point-of-care ultrasound adopts itself or adapts itself, or providers adapt it to different settings. So it's great to learn how tests have to be managed differently, their results, and I'm sure we'll have some questions about that. Thank you so much for participating.